All right, we are going to move ahead and get started. So again, I just want to say good afternoon, everyone. We are so happy to have you, and thank you in advance for attending our session today, which will be an engaging discussion on system-level opportunities to improve maternal mental health. We have two experts from Mathematica that are lined up to speak to you today, and they will share stories and strategies that will help you as you look to provide more equitable and patient-centered maternal mental health care. Next slide, please. My name is Shannon Lee, and I am a senior program manager at PCDC. As I said earlier, I'm super excited to be here with you all today and very much looking forward to our discussion. Next slide. For those of you that are not familiar with PCDC, we were founded in 1993 as a nonprofit dedicated to expanding and transforming primary care in underserved communities to improve health outcomes, lower health costs, and reduce disparities. Next slide, please. So to be clear, I will read the disclaimer on this slide word for word. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, CMHS, the Substance Abuse and Mental Health Services Administration, SAMHSA, or the U.S. Department of Health and Human Services, HHS. Next slide, please. This is the third webinar in our Operationalizing Integration series, and I want to briefly highlight our previous sessions. In our first webinar, Mitigating Burnout Through Integrated Healthcare, we saw expert presenters discuss the state of providers and present a real-world case study on how operationalizing integration benefited one healthcare team. In our last webinar, Collaborative Care Management Foundations, a 101 primer on practices and possibilities, Dr. John Kern provided information on the evidence, principles, and concrete functions of collaborative care management. If you missed either of these webinars, check out our tip sheets for practical information related to operationalizing integration. Next slide, please. I would also like to highlight our Integration at Work SAMHSA webinar series tip sheets. Held last year, this series provided a roadmap for behavioral and primary care collaboration. And all recordings and tip sheets from Integration at Work can be accessed by following the link that is shown on this slide. And as an FYI, today's slides and recordings will be sent out next week, so you'll have access to all the tip sheets and the recording links. Next slide, please. So before introducing our speakers, we would like to know a little bit more about you. Let us know where you work, your primary role, and how you would rate your current skills and comfort with describing the personal and societal impact of perinatal mental health conditions, the factors driving poor perinatal mental health and its inequitable impact, and promoting coordination between maternal, mental, and primary care. And just a quick FYI, if you don't see your setting or your role listed, feel free to drop it in the chat. We would love to know where you're joining us from. And just as a reminder, at the end of today's session, we will transition into our half-hour open office hour session. And again, today's slides and recording will be made available next week. And then we can move to the next slide. So next, I would like to introduce our presenters, starting with So O'Neill. So has dedicated her more than 2-decade career to reducing health disparities and promoting health equity for mothers, children, and their families, regardless of race, ethnicity, gender, religion, disability, sexual orientation, gender identity, socioeconomic status, geography, and other visible and invisible characteristics. She currently directs Mathematica's domestic health philanthropy portfolio, which has supported work for more than 50 philanthropic institutions, nonprofits, and professional associations. So partners with clients and Mathematica staff to develop and implement projects that generate evidence and translate it into action for social good. She has worked extensively with domestic and international community-based organizations and local government agencies to bring a participatory approach to strategy development and complex mixed methods research. Her experience as a first-generation immigrant and service as a Peace Corps health volunteer in Africa helped her recognize the importance of centering equity in her work and understand that systems and policy change are foundational to improving well-being. I would also like to introduce Kara Zivin, who has over 20 years of experience conducting research and evaluation studies of clinical, functional, and quality of life outcomes for vulnerable populations with behavioral health conditions, including women in the perinatal period, older adults, and veterans. Kara is also the Marcia Wallenstein, MD, Collegiate Professor of Psychiatry at the University of Michigan Medical School and a research career scientist at the U.S. Department of Veterans Affairs. She has published over 200 peer-reviewed papers, including in the American Journal of Psychiatry, the Journal of the American Medical Association Psychiatry, American Journal of Public Health, Medical Care, and Health Services Research. Kara, and so we can't wait to see what you have in store for us. And now I pass the baton to you all.
Great. Thank you so much, Shannon. And really excited to be here and joining you today, especially since today is World Maternal Mental Health Day. So a well-timed webinar. So we are here today to focus on presenting to you some systems level opportunities to improve maternal mental health. These system level opportunities are really around where healthcare, public health, and social policy intersect. A little introduction to those perspectives we bring. Both Kara and I are not physicians, but researchers whose work has centered around understanding the intersection of social determinants of health, healthcare delivery, and public health, and how all of these intersections influence maternal health. Our lens is in generating and translating evidence for decision-making and action, and you'll see our presentation has that type of leaning. And given our background and based on the poll, there's a diverse audience today. We'll focus on issues ranging from policy to practice that influence maternal mental health outcomes, and we'll particularly focus on perinatal mood and anxiety disorders, which are often referred to as PMADs. We hope that there'll be a little bit for everyone to take with them today from our presentation. Next slide, please. So today, to ground us in the reality of the impact, Kara will first share with you some personal context that drives why she does this work and why many of us personally think it's very important to take on. We'll then step back and provide broader social context for maternal mental health conditions and highlight a series of gaps and unmet needs in the system. And then next, we'll turn to ways to potentially improve access to and quality of care by addressing barriers to effective care. And then we'll share with you some models for integrated maternity and mental health care. And these models will provide you with an overarching understanding of how some of them get implemented, but we're not going to go into the nitty-gritty or specifics today. And then we'll provide some concluding thoughts and open it up for questions, but please also feel free to put questions as we are speaking in the chat. Next slide, please. Aligned with our agenda today, we have 4 primary objectives for you, as indicated here. First is to describe the personal and societal impact of perinatal mental health conditions. The second, present the factors driving poor perinatal mental health and its inequitable impacts, and discuss solutions to address the system's drivers, and then promote coordination between maternal mental and primary care. Next slide, please. So now I will turn it over to my colleague, Kara, to share a little bit of why it's so important to look at this condition.
In 2021, I published an article in a special issue of the journal Health Affairs on maternal mental illness, as shown here, about my personal experiences with perinatal mental illness a decade earlier, coupled with policy recommendations from my perspective as a researcher. After struggling with my moods as an adolescent, I decided to pursue a career focused on public health and policy approaches to improving access, quality, and costs of mental health care at the population level. I wrote peer-reviewed papers, pursued research grants, analyzed data, and gave lectures. In 2010, I became pregnant for the first and only time after a whirlwind of changes in my personal life, including getting remarried, becoming a stepmother, and buying a new house. I wanted to have a medication-free pregnancy and stop taking antidepressants. First trimester insomnia led to intense depression and anxiety as my pregnancy progressed, leading me to a place of desperation and suicidality. In 2011, during my 8th month of pregnancy, I took an overdose of multiple medications and woke up 2 days later in the hospital. I spontaneously went into labor the next day and gave birth to my son. He ended up in the neonatal intensive care unit, and I was transferred to the psychiatric ward. My son was discharged after 4 days, and I followed him 3 days later. When continuing to remain ill for weeks after my hospital discharge, I made the difficult decision to go under electroconvulsive therapy. I have almost no recollection of that period, a known side effect of ECT. Although the treatment worked and my mental health improved, I face a substantial uphill climb to return to health, functioning, independence, and becoming a mother. From the outset, I realized that if I had had a different skin color, educational attainment, financial circumstances, marital status, employment status, insurance coverage, or zip code, the outcomes for my son and me could have been substantially worse. After years of hiding due to guilt and shame, my personal experiences with PMADs led me to pivot my public health research career to focus on trying to address unmet needs and gaps in access to and quality of care for mothers, infants, and families. Over the last several years, our Mathematica team has developed a portfolio of work in this area. Next slide, please.
Thanks, Kara, for that really powerful framing and revisiting such a hard time, but it just brings home why this is so important to work on. With that, I'm going to zoom back out to provide a broader framing for peri-mood and anxiety disorders and its impacts. So if we could go to the next slide, please. So as we heard from Kara, there are some really dire consequences to peri-mood and anxiety disorders if left untreated. And on the personal side, people with untreated PMADs are more likely to have preterm births, low birth weight, developmental delays, have thoughts of suicide, and engages in substance abuse. And this can be associated with lost productivity due to their inability to work and a number of other emotional, physical, and economic stressors on their families' lives. So, beyond the individual level, we start looking at the population level. PMADs are among the most common complication of pregnancy and childbirth. They affect around 15% of people, and it's actually estimated that prevalence is as high as 40% in some populations. So there's definitely some inequities within the presentation of PMADs or the prevalence of PMADs across various populations. And the frequency and toll of these conditions have really unquantifiable impacts. And that's why we had Kara speak first. And to help us at least look at a metric of impact, as Kara had mentioned, we have done several studies to look at the societal costs of PMADs in economic terms, because these terms tend to speak more to legislators and those that are making policy. And in our studies, we estimated that PMADs costed society in terms of medical and social expenditures a lot, 14 billion. And the largest costs included loss in economic productivity among affected mothers, more preterm births, and increases in other maternal health expenditures. So next slide, please. So as I mentioned, there's some inequities and disparities that exist in the prevalence, screening and diagnosis and treatment of PMADs. Not surprisingly, people of color face racism and other historical disadvantages that contribute to higher occurrences of PMADs, and barriers have made it difficult for them to access care. People living in poverty have also been shown to have higher rates of PMADs. And within some of these populations, they may live in a culture that stigmatizes mental illness, further compounding the issue and leading to underreporting. So given that many of these groups are underrepresented, we also have limited evidence about what can help. So this is the setup of how some of the bigger issues of trying to solve this problem. Next slide, please. So I mentioned some of the identities in the previous slide that face disadvantages in occurrence of PMADs and incidence of PMADs. And I wanted to point out here that if you identify as someone living in poverty from a disadvantaged racial or ethnic group, that this can actually compound your risk for PMADs. This is something we call intersectionality. So having one or more identities that are already disadvantaged can really lead you to have a higher compounded risk of getting PMADs. And this is the best I could find for an example of intersectionality related to maternal health. It's a study in Nepal that actually tries to quantify evidence of how multiple intersecting identities can influence the receipt of maternal health care. As you can see, if a person has all the characteristics of marginalized ethnicity, low literacy, and in poverty, they're more likely to get fewer than 4 prenatal visits, and they're also less likely to have follow-up postpartum than those identifying with only one of these characteristics. So as we discuss a little further about PMADs, it's important to consider a person's risk in terms of how many intersecting identities they may have, and some may be visible and some may be invisible. Next slide, please. So given the prevalence and disproportionate burden on certain groups, this diagram shows us where we can conceptualize where people fall through the cracks. So our conceptualization of where people get missed during the treatment cascade here is being shown based on a publication by Cox et al. In 2016 in the Journal of Clinical Psychiatry. And the article, just so you all know, is titled "The Perinatal Depression Treatment Cascade: Baby Steps Toward Improving Outcomes." So as shown here, people can fall off right at the beginning of the cascade, whether or not they're screened, based on whether or not they're screened, or are screened and not recognized as having PMADs. And then the next thing is, if they are recognized, that another place they fall off is that they may not initiate treatment. And that can be for a lot of reasons that we'll talk a little bit more in the next portion of the presentation. So then in the next cascade, if they get treated, it's possible that they do not get adequate follow-up or treatment. Again, for any number of reasons. So that's another place to fall off as we go down the cascade. And whether or never getting treatment or inadequate treatment, this leaves people with unremitted depression. And for some, this ends in harm to themselves and to their families. So just a little background on this cascade as well. Cox et al. Conducted a systematic search of existing articles to highlight the issues at each of these points within the cascade. So we're going to talk a little bit about how the strategies and the issues at each point in the cascade. Next slide, please. So now we'll pivot to discussing breakdowns in the system. So we've kind of laid out the background, the scope of the issue, and we're going to now talk about what is broken in the system that caused people to fall off during that cascade. And we'll talk about the breakdowns in the buckets of policy, infrastructure, and health systems. And, although this may not feel as relevant to day-to-day provider practice, we believe that understanding policy level and infrastructure issues can influence how you approach your patients and some of the additional supports that you might be able to refer them to, such as like community-based organizations that help people enroll in Medicaid and the health insurance marketplace. Next slide, please. So let's start with whether people can access the resources they need, whether or not they get screened at all in that cascade, and whether policies can help people do that. And within the spectrum of the policies, insurance is definitely one of the key ones on whether or not people get the healthcare they want and need. And despite recent gains in the number of people who have access to health insurance, 26 million or 8% of people in the US lack health insurance. And this includes a 5% rate of children that were uninsured in 2021. So in thinking about this rate of uninsured, how does that translate? And it translates to over 1 in 10 women still do not have access to health insurance, which then limits their ability to get services they need. And then when we look at it by race, the uninsured rate is 5 percentage points higher among Black non-Hispanic populations than white populations, and 13 percentage points higher for American, Indian, Alaska Native, and Hispanics. So this lack of insurance is a key starting point for people to not be identified for PMADS or get treated at all or adequately for it. Next slide, please. So even if policies are in place that give coverage to everyone, could you click on the next thing? Yes, thank you. There are other barriers to accessing care that have to do with where they live, the resources available to meet their particular needs and their life circumstances that enable them to access care if available. And we can consider these as components of the health system infrastructure and think about them in terms of serviceability, workforce capacity, and other enabling factors. So as relevant to PMADS in particular, we consider whether mental and maternity care are offered at places where all people can access it. And when we look this over, 1/3 of Americans live in a mental health provider shortage area. And that's approximately 2.2 million women of childbearing age live in maternity care deserts. That's a lot of people that live in places where there's no mental health or maternity care providers. And if these services are offered, there might not be very many of these providers. Can you click on the next thing? Thank you. So here the point is that there might not be even if they live in places with providers, there may not be very many of them, meaning that there is a workforce capacity issue to providing the services needed. And they may have to wait a long time for care. So the care is not timely. And next click. And even if there's enough care for everyone, another key consideration is that people might not have the childcare or transportation or work at times that don't allow them to easily get the care they want. And these are the types of enabling services that are really important to consider when we think about healthcare accessibility in general, but that are also very important considering the disproportionate burden of PMADS on people of color and people living in poverty that often work jobs that may not allow them any flexibility in their hours or may have limits on their transportation and so on. Next slide, please. So we've gone from the point where there's this big policy umbrella. We've talked about the health system infrastructure. So the person actually, if they get through all of those barriers and they actually enter into the health system, there are barriers during various stages of the perinatal period. let's consider pregnancy and postpartum periods. And we'll break up postpartum care into that for the child and that for the mother. So the care needed during pregnancy period is generally provided by an OBGYN. And any PMADS, interestingly, is identified and managed by the OBGYN. However, often the OBGYN might not feel comfortable making the diagnosis or might not know where to refer to, or might not have a system for consultation on maternal mental health issues. Furthermore, they might not be comfortable managing the condition with the support of a mental health without the support of a mental health professional. So during the postpartum period, so that's during the pregnancy period, like who is responsible for the care. And during the postpartum period, pediatricians can often use the early and periodic screening, diagnostic and treatment, EPSDT, benefit under Medicaid to screen a new mother for depression during an infant's well visit. Yet, whether, when, and how pediatricians refer the mother to a mental health services is not completely clear. So they can screen, but they're not sure what they're supposed to do in terms of follow-up. So someone might be identified, but then not get referred or get the care they need. So that's another place for a breakdown once the person gets into the health system. And another place time postpartum where the health system might leave people with PMADs falling through the cracks is when the mother is transitioning from obstetric care to primary and mental health care. So, their mental health was being managed by their OBGYN, and now they're going back into primary care or their regular mental health care. And often what happens during this period, there's some uncorded care or communication could happen that could mean that PMADs identified during pregnancy and might not get effective treatment. And, after the 3-month postpartum visit, there could be a long gap too between the last postpartum visit and then having another visit in terms of primary care or regular care. And so any incidence of PMADs during this time might leave mothers struggling, not knowing what's going on and without supports. Just as a statistic, so you all know, less than 20% of pregnant and postpartum women are screened for depression. And Black and Latino people are less likely than white women to initiate mental health care after delivery. So for perinatal postpartum depression, excuse me. And so, these are just some health system considerations of where once they get into the health system, they could fall through the cracks. So next slide, please. And now I will stop speaking and turn it over to Kara.
So in the context of these system breakdowns, we're now going to turn to talking about some potential solutions. In presenting these solutions, we reiterate what So mentioned at the beginning, that we will focus on framing these solutions at a high level and not getting into the weeds of physician practice. We hope that this approach will give you some ideas to consider implement as you go forward. Next slide, please. So addressing the policy level would include supporting policies that expand coverage and within existing policies help patients get coverage and access to care they need. So I'm now going to walk through a few examples. The Affordable Care Act had what was known as the family glitch, where people's family members could not participate in the marketplace for their family members if their employer offered coverage, even if the family coverage was not affordable. Fixing this glitch would cover about 5 million additional people or family members, a welcome development that took place in 2023. Expanding Medicaid in all states would increase insurance coverage for several million additional people. The American Rescue Plan Act of 2021 made it easier for states to extend postpartum Medicaid coverage from 60 days to 12 months. If all states adopted this option, up to 720,000 people across the United States would have access to Medicaid and the Children's Health Insurance Program, CHIP, coverage for 12 months after pregnancy. Single-payer health insurance would reduce administrative barriers and ensure access for all. This does not mean we would have government-run healthcare, but each person would have coverage. As someone who's spent many years studying health policy, I urge us not to lose sight of that option, even if it often seems like a political non-starter, because it represents the best, most efficient, equitable health system, according to the American Public Health Association. Making sure that people get access to coverage or alternative providers if they are eligible can help. One way to do this is to make the enrollment process easier. For example, automatic enrollment during COVID-19 helped over 14 million people have continuous health coverage. Access to doula support has also been shown to lower the odds of getting PMATs. Next slide. Patients may face limited choices among plans and providers. To address this issue, we must strengthen network adequacy for marketplace plans as part of improving maternal equity. The Center for American Progress argues that to improve maternal health access and outcomes for millions of pregnant and postpartum people in the United States, the federal government must ensure that health insurance plans available through the ACA marketplace offer robust maternity care provider networks. ACA marketplace plans have narrower networks for mental health than primary care. Regarding Medicaid, specialty mental health providers were more likely to accept Medicaid coverage after their states expanded eligibility under the ACA. Besides improving provider networks, other ways to improve choice include options such as better provider directory guidance, which would ensure that directories operate effectively and contain comprehensive provider information. Although these options do not sound glamorous, they would make a meaningful difference in expanding options for patients. Next slide. At the infrastructure level, providers can also improve access. Choices of plans and providers may remain limited, and providers will remain unequally distributed geographically. Two strategies for addressing provider shortages involve motivating providers to practice in low-resourced areas and expanding telehealth care services. Governors in multiple states have pushed for higher compensation for healthcare workers, raising Medicaid reimbursement rates, expanding educational opportunities for healthcare providers, tuition reimbursement, waiving licensing fees, and loan forgiveness. The pandemic provided opportunities for rapid changes in telehealth, and it could prove beneficial to retain options after the public health emergency ends. This could include expanding telehealth services and allowing clinicians from other states to provide telemedicine. Flexibility will remain crucial to address ongoing and expected workforce shortages to provide consistent mental health and maternity care services. Next slide. To address challenges with referrals for perinatal mental health care, one option includes integrating mental health providers into obstetric care settings. Another option involves having mental health providers consult with obstetricians to increase their comfort with managing and referring patients to address their mental health needs. Multiple research studies, including clinical trials, have shown that integrating mental health care into outpatient obstetric settings is feasible, acceptable, sustainable, and effective. This would provide an opportunity for a patient to receive care in a single setting rather than assuming that a patient can and will take a referral for an external mental health provider, schedule, and then attend an appointment. Mental health provider shortages also may prevent patient access to local services. For example, here where I am in Michigan, very few psychiatrists practice in the entire Upper Peninsula. This gap in accessibility led to the creation of the Michigan Child Collaborative Care, or MC3, a statewide telepsychiatry consultation program that provides support to primary care providers in meeting the mental health needs of youth and perinatal women. You may also be familiar with similar programs in other states, including the Massachusetts Child Psychiatry Access Program for Moms, or MCPAP. These two approaches taken together would help address the gap in availability of and success in facilitating referrals to needed mental health services for pregnant women and new mothers. Finally, I want to remind everyone that what we measure drives what we do. I refer to notably low rates of screening, diagnosis, and treatment, as we discussed before. A few months ago, data from the first set of maternal depression screening data from the Health Effectiveness and Information Data Set, or HEDIS, became available. Less than 20% of either Medicaid or commercial plans conducted screening either during pregnancy or postpartum. We must do better to improve detection and outcomes for pregnant individuals and new mothers. The bundle focused on perinatal mental health symptoms includes screening tools, response protocols, provider education and readiness, incorporating mental health into multidisciplinary rounding, and ongoing monitoring to evaluate processes of care and treatment plans. Next slide. So to follow up on these ideas and recommendations, we wanted to give you some examples of promising models that may serve as examples for consideration to address gaps in care and unmet needs. Next slide. We now return to the perinatal depression treatment cascade that we mentioned earlier. We wanted to incorporate data that demonstrated ways to reverse this cascade. Implementing an integrated behavioral health care program, including screening to treat, improves screening rates. When co-located services for obstetrics and mental health are available, pregnant and postpartum individuals are more likely to follow up with needed mental health care. Individuals who adhere to prenatal care are more likely to adhere to mental health care and vice versa than those that do not. Making progress at each step along this pathway leads to better outcomes for mother and child. Next slide, please. We are now going to walk through some examples along the continuum of models that can address perinatal mental health conditions. These start with first, consultation and support, second, practice change to get it into the provider workflow, 3, provider co-location of both obstetrics and mental health in the same location, and 4, integrated or collaborative care between mental health specialists and obstetric care. At one level, perinatal psychiatry access programs provide psychiatric consultation to obstetric providers. The next level involves an additional support of training, toolkits, and technical assistance to support maternity care professionals. Co-location could look like a nurse practitioner trained in psychiatry and obstetrics embedded in the obstetric clinic, and perinatal nurses, often the first professionals to recognize women who are experiencing mood changes, can easily refer women for follow-up. Collaborative care integrates mental health professionals with the obstetric team. Now I will walk through each of these types of models in more detail. Next slide, please. Of the options available, resource supports are the most commonly available, currently 14 states as shown here. Next slide. One of the well-known models, MCPAP for Moms, appears here. I draw your attention to the red box that highlights program activities in terms of engagement and training of providers, consultation services, resources, and referrals. Next slide. Practice change extends the resource support in several ways. For the prior example of MCPAP for Moms, they have created a new approach called the Program in Support of Moms, or PRISM, which is a more proactive approach than MCPAP for Moms. PRISM will empower obstetricians to develop processes to treat their patients' psychiatric needs in their own practices, ensuring that their patients do not fall through the cracks in the depression care pathway. PRISM leverages existing resources to help practices integrate depression into obstetric care. Next slide. I now turn to co-located practices. In the example shown here, historical indicates separate practices, meaning postpartum visits are separate from mental health visits, and contemporary represents co-located. You can see that mental health referrals increased after co-location. Another program not shown here added a co-located psychologist to a perinatal psychiatry clinic. In that instance, the psychiatrist saw more patients, decreased wait times until new visits, and decreased no-show rates for established visits. Next slide. Finally, we turn to collaborative care models. This figure on the left is from a Denver-based clinic, which indicates the process of integrated care, although we note that this image is not specific to maternity care. On the right, we can see levels of severity and how they might apply in collaborative care settings. Collaborative care titrates the delivery of behavioral health care to treatment intensity required for a given patient. Collaborative care typically begins with the provision of psychoeducation about depression and initiation of evidence-based brief psychotherapy and/or pharmacotherapy. If the patient does not respond to the initial line of treatment, care gets augmented. Very often, the primary care physician can implement psychopharmacotherapy changes, thereby efficiently reserving specialty mental health care by a psychiatrist for those patients who do not respond after earlier steps in the treatment algorithm. Proposed benefits include improved access to behavioral health, patient-centered care, receipt of behavioral and physical health care in the same familiar setting, and improved clinical outcomes. Collaborative care achieves benefits through adherence to 5 core principles: patient-centered team care, population-based care, measurement-based treatment to target, evidence-based care, and accountable care. Next slide. We also wanted to include another example outside of the continuum of care that we just described that provides an alternative approach to addressing perinatal mental health needs. We show here an example from the Birth Sisters program, an innovative multicultural doula service that offers women sister-like support during pregnancy, childbirth, and the postpartum period. Trained to give social support to at-risk mothers in their community and connect them to needed resources, Birth Sisters offers prenatal home visits, labor support, and help at home after the baby comes. By mothering the mother, they play an important role in empowering women, their children, and communities. I know personally I benefited greatly despite my distress during my pregnancy from a doula. Next slide, please. Although we have shared a range of options, I wanted to acknowledge that limitations persist. As you can see here, many states lack perinatal programs. As we moved through the continuum from least to most integrated, we had fewer examples to draw on from practice or the literature, and existing programs had small numbers of individuals who could access them. Several of the programs relied on grant funding or donations that ultimately ended, leaving the future of those programs and reimbursement uncertain. In other words, no pun intended, we're still in the infancy of effective and widespread perinatal mental health service. Next slide, please.
So that's all we have for now today. To wrap up, if we could go to the next slide, please. We hope that you'll take away the following key messages. First of all, multiple factors impact people's ability to get maternal mental health care. And some of this can be addressed in the healthcare settings and others can't, but it's vital to think about health as involving whole person care. Having said that, there is something providers can do within the healthcare setting. They can ensure implementation of government policies so that people have access to care. For example, you all could have people on site to help with enrollment and insurance of eligible people, offering virtual services such as telehealth to reach those that might not be able to come to the clinic, and thinking about how to collaborate and integrate care between obstetrics, mental health, and primary care colleagues. This isn't an issue that's limited to maternal mental health, but plagues multiple conditions. And if we can figure it out for maternal mental health, we can have wide-ranging impacts on many conditions and people, and by extension. And in the end, improve quality of life and minimize societal costs of these conditions. Next slide, please. Again, this is the end. Kara and I, and we're happy to take questions. Kara and I are honored to have been able to speak with you today, and we'll also leave you here with some resources to learn more about the state of maternal mental health conditions, materials that you can use in health centers, and support resources for patients. Next slide, please. That's it for us. Our slides will be available as Shannon said at the beginning. And we have a whole host of references for you.
All of the references. All right, thank you, So and Kara. It was, particularly meaningful, Kara, to have you share your experience and set the tone for the importance of equitable, patient-centered maternal mental health care delivery. So quickly, everyone, before jumping into the open office half hour, we just ask that you answer the question that's showing on your screen now. And then once you've answered this, please feel free to start dropping questions in the chat. We did not have a ton throughout the session. But I have quite a few, so please drop them in the chat and then we will move on. And then also, if you feel more comfortable messaging me directly with your questions, feel free to do that. I will make sure that they are addressed in the office hour. And we will start with those who have already submitted questions. Okay, let me get to that. So the first question that we have is related to the role of midwives and doulas in prenatal and postpartum mental health screening and treatment. So I know that throughout the session you mentioned birth sisters and mothering the mother, but can you speak more to the role that a doula may have, a doula or a midwife may have?
Kara, did you want to take that, or
I can start with
Yeah.
part of it, although I realize that there are some challenges. It's my understanding for both, for reimbursement for both doulas and midwives. Some of that, I believe, is a state to state under Medicaid or other coverage. But, I think doulas, can at any point in the care pathway be a support for mothers, potentially sort of outside of the most clinical aspects, but and different states are also exploring or deciding to cover doulas under their programs, and similar with Medicaid, or sorry, with midwives. I admit I don't have at the tips of my fingers all of the information exactly of how that would work. So I don't know if you have more information specifically about midwives.
I don't have more information specifically about midwives. I mean, what you said about doulas makes sense. I know that doulas have been proven to be helpful because they provide that emotional and mental support to pregnant women and postpartum people. But I don't know as much about midwives. I recall they can screen and do screen and refer as well. So I don't know if that helps answer the question. Sorry, I was just distracted because I saw Representative Jamie Belzito from Massachusetts in the audience. And I wanted to give a shout out to her.
And also some people who perhaps have better or more information about both midwives and doulas look like they are providing information in the chat as well. So I'm hopeful that is helpful.
Yes, thank you guys so much. It sounds like there's a little bit more research on the midwife piece, but what you shared about doulas was great. So I have a couple of other questions for you. Let me pull those up. We have many of the observations and suggestions have implications for the training pipeline. What recommendations do you have for building the workforce for many of these excellent options?
Kara, I think you're better.
I know it's a
positioned
really
for that.
huge and important question, and we talked about it a little bit of, right, how do you incentivize people to both go into these fields and then where they are located, right? Because we know that both mental health and OBGYNs are, not equally distributed geographically, especially in rural or less sparse areas. And I think that is something that the professional organizations are aware of and looking at. The March of Dimes in particular has explored this topic. And I think, it is really challenging. And, I don't know if that's a legislative type of thing in which we need to provide more funding, whether that's, medical school loan forgiveness or, other types of incentives for taking these types of positions. And very honestly, with some of the changes in access to reproductive health services that many of us are aware of, that has implications for which providers seek to go into the field and where they choose to practice. So I think, if anything, this issue remains ever more, important, these workforce challenges.
Thank you, Kara. I am going to move on to the next question, which is, are payers and or reimbursement? Have you noticed that those are challenges related to the provision of care in this way? And if so, what are the best ways to mitigate that and move forward?
I think it's an insurance coverage issue.
Mhm.
That is a payer issue. Of course, there's different levels of payer issues. I think this is from Representative Belzito. In Massachusetts, we have rather generous Medicaid postpartum coverage in comparison to some other states, and that really helps a lot. But the rate at which Medicaid reimburses is lower than other providers, and that can make it a barrier for people to obtain the care that they need. So I think it's kind of dual. It's both like a reimbursement issue and a coverage issue. Kara, I don't know if you wanted to add on to that.
Yeah, I mean, I think you've covered a lot of it, but I think similarly to coverage for specific services, like we were talking about, right? It's not just a matter of whether you can have a doula, but how much would they be reimbursed? But similar in terms of mental health care. And we know that mental health providers have one of the highest proportions among healthcare providers of not taking insurance or only being in private practice, because the reimbursement rates are often so not competitive for them. And so then that gets you back to these access barriers of how do people get into seeing providers, even if they seek to. And so, as So said, I think it is both whether something is covered and how well it is covered and under which types of plans.
Definitely. Thank you both. And let's see, next question. Can you share any existing trainings or trainers who could assist providers to better support mental health by conducting screenings, providing whole person care, et cetera? I think we can connect with you guys offline and share that with the participants in the form of our tip sheet, if there are any that you recommend. I don't think we have any additional participant questions. So I do have a couple of questions that I thought of as you all were presenting, and just wanted to know if in your research, have you come across any examples where mental health care has been successfully integrated in obstetric settings? And if so, can you share a little bit more about that? I know you mentioned it as an option, but have you seen it done successfully?
That was an interesting thing that we were trying to address, because even starting out with the 14 access plans, which again, those were even just, psychiatric consultation services. They were not these embedded clinics. I feel like we found a couple one-offs here and there that again might have been a part of a clinical trial, but I don't know that there are a ton that are out there that are ongoing. And I'm sure someone maybe in the chat would know of. I know individual institutions have tried to open them. For example, there's one, I believe, in Pittsburgh. I want to say it's at the Allegheny Clinic, where it was actually in memory of a woman who died related to mental illness postpartum, and so they've tried to build this. And I could get the exact name for you. It's the Joy. I'll look it up. But anyway, it
Okay.
just to say that. I wish I could say there are tons of these and you just didn't hear of them, but I think that's part of the challenge. I mean, it's a challenge. I don't know if this makes it better or worse, but trying to use this model in any kind of mental health care integrated with primary care or pediatrics or other things. So, in some ways, the collaborative care models that we were talking about, are learned from those other disciplines. So there's just so many different challenges to implementing them successfully, including reimbursement specifically for the care collaboration piece.
Right.
So I wish I could point you to lots of great examples, but I feel like that's why I was saying we're sort of still in our infancy in this realm.
No, that definitely makes sense. So what recommendations would you have, like based on what you've seen, what you know about the challenges to do this work and kind of implement collaborative care across the board, as far as with maternal mental health, what recommendations would you have for an organization that is kind of just starting to think about that type of integration?
Some of it is a culture shift, I
Mhm.
think, honestly, you know what I mean? Because I feel like many parts of healthcare operate in silos, and I think there are some challenges of people feeling comfortable in their lane with the types of clinical care that they provide or medications they may be comfortable with, but trying to figure out how teams can work together in terms of their processes or even their physical layouts of who sits where and who talks to who about which types of care. You know, this is something that's actually been built in the Department of Veterans Affairs a lot, just I can speak about, of just, you know, having someone that you can walk down the hall to the provider and they can talk amongst each other, especially when women may not feel comfortable talking about their mental health conditions. They may be really afraid of what's going to happen to them or their baby or their family. And so trying to build this space where we're not dividing up, this is your maternity care and this is your mental health care, but this is whole system, whole person care, I think could go a long way. So I don't know that I exactly answered your question there. I don't know. So you have anything you want to add?
Yeah, I think it's a cultural shift. I think it's a shift in the incentive system too for the care coordination, and how that gets reimbursed. You alluded to Kara. Um, I think looking at the chat, that's why some of the comments related to family medicine and the way that family medicine work really resonated as a way to think about provision of care. And I think this is a problem larger than maternity care. I think it's a whole healthcare system issue that we need to break out of the silos a bit and figure out how to reimburse for care that coordinates not just healthcare, but social determinants of health too. And so it's kind of a bigger issue. That's probably not very helpful, makes it seem
No,
bigger and
it
harder.
is, yes. Thank you both. We did get another question dropped in the chat. And would you know if there is a specific push for ACOs and payers to include maternal behavioral health in managing their health as a part of their value-based contract negotiations?
I think that would be wonderful if that could happen. I feel like we're not there yet, and I wish we were. I mean, we're barely at the stages of is a woman getting screened for depression ever during pregnancy or postpartum? And those recommendations have come out in less than the last 10 years. So, I mean, I think that would be important because, right, again, a lot of this is about incentives. If there are incentives to do it, people find a way to make it happen. Without that, it tends not to happen. And so I think that is an important consideration or potential opportunity.
Yeah, I haven't heard of anything. That doesn't mean it doesn't exist. I don't really work as much in the value-based care and payment arena, but I think it's a fascinating idea to think about doing something like that that would incentivize whole person care. And then I think part of the issue then, just to geek out a little on you, is like, how do you measure that value really to the patient for this coordinated care? What are the benchmarks? What are the comparisons? But it's a really interesting thought.
Definitely. I wanted to ask if you all could speak more about solutions related to bolstering consultation systems as well as diagnosis by the OB and kind of like increasing that comfortability. I know, Kara, that you mentioned PRISM and some of the work associated with that. Is there any more that you can share related on increasing that level of comfort?
It's an interesting question, right? Because, it's my understanding that these types of services are provider to provider support. So, if I'm an OB and I have a patient and I don't know how to either start them on meds or tweak their meds or, manage particular other symptoms they're interacting, and I can call on another mental health provider, whether or not they're local or somewhere else, and talk through the case and get advice. It may be beneficial for that particular case, but it also may help my confidence more generally when I see other similar cases, especially if this happens over time. And I think that's the idea of these programs that have been, um, and yet again, they're only in 14 states, but I still think that um, that seems to be one way, the sort of provider to provider guidance, um, because many women get the bulk of, if they're going to get any care during pregnancy, it probably is going to be from the OBGYN more so than potentially a mental health provider or their primary care uh, physician. So, does that answer your question, or do you have?
It does. It does.
Yeah, okay.
Thank you. And then I did want to ask for you to just share some insight on how accepting patients that have Medicaid would aid overall in reducing disparities associated with PMAD. I know that you mentioned it briefly, and I know that we've talked a lot about access and everything, but maybe if we could just dig into the benefit of accepting patients that have that particular type of insurance.
Well, I would say that Medicaid covers roughly, depending state to state varies, roughly half of deliveries. Medicaid is also one of the largest providers of mental health services. So if people don't get either or both of those things, I mean, there's a huge gap, right? So to the extent that, and often there's great needs, not just health related needs, but broader, psychosocial needs for that population, or co-occurring illnesses, or need for other supports. And so having Medicaid engaged in this work, I think would be, or people who are willing to accept Medicaid would be really beneficial. I don't know, so if you want to add anything to that.
Yeah, I was gonna say about how, there in one of our slides that estimates that if you had a coverage after Medicaid coverage a year after delivery, um, that about 720,000 people would have coverage to identify those issues if they happened. So I think that gives you kind of a parameter, and the idea that it affects about at least 1 in 5 pregnant people or postpartum people. So, I mean, it's quite a number. I think that there's so many intricacies in how comorbidities interact. It's kind of hard to say a specific number, but that's how
I
I.
also would say that, this issue of postpartum Medicaid extension
Mhm.
is really important, because we know that illness doesn't necessarily turn up right away after delivery, or, end within 60 days of delivery. I mean, when you think about that, Medicaid traditionally had only covered women who are eligible due to pregnancy up to 60 days postpartum. I mean, that's 2 months. Like, people can be having challenges, and even getting into healthcare. Many of them at most have had one postpartum follow-up visit with their OBGYN, 6 weeks after delivery, and that's it. And so and we know that it's not just, mental health diagnoses, but overall maternal morbidity issues can extend up to a year. So I think that people having coverage to get the care that they need in the timeframes that are more clinically or socially meaningful could also be really helpful.
Thank you, Kara. And so I think the final question that I have is just related to sort of your conversation related to the maternity care deserts and like the mental health gaps. And I know that you spoke about some policy I don't know, I guess some solutions, right? Potential policy solutions related to incentivizing, providers to go to these particular areas, or the expansion of telehealth or caring across state lines or providing care across state lines. Is there anything else that's like kind of on the cusp for us to look out for related to kind of hopefully a shift in providers heading to these areas and being able to provide care?
Yeah, what was really interesting is I did a recent I have a recent project in Missouri, and during COVID, what happened was they expanded, and this is for reproductive health and maternal health, they expanded the mileage coverage for APRNs, and that actually improved access to folks living in rural areas. But now with the unwinding and states like going back to their pre-COVID policies, that has actually become more of an issue. And so COVID has actually taught us a lot about how to reach rural populations or reach these deserts. And I just highlight that as beyond telehealth, beyond, broadband coverage, that this traveling APRNs and traveling medical providers has been a very interesting development to help reach people.
That's exciting. And it'll be interesting to see how that plays out over time. I think Jamie dropped in the chat a workforce bill that's in Congress and indicated that Massachusetts has the same bill. So it seems like, some states are coming along, but, as with most things, some are slower than others. So I do want to take this opportunity really quickly to ask any of our participants that are still on, if they have any questions or anything that they would like to drop in the chat. I really want to make sure that you are taking advantage of this time that you have with both So and Kara. They are both very, very busy ladies, and we're super glad that they could come and chat with us today. But please take advantage of this time. I know that I have probably commandeered the Q&A session, but if you do have any questions before we move on, please let us know. And then, So and Kara, is there anything that you'd like to share before we wrap up, like related to your issue brief that went out today, or just anything that you would like for participants to kind of check in on?
I mean, I think you guys have asked really important questions. I wish I had better, more complete answers about, sort of where policy was or going to drive things, or, how to, increase coverage, in terms of reimbursement or in terms of providers. But I'm hoping that with, providing this kind of information and for sharing, whether it's personal narratives or data, that we can draw attention to this issue, because, to benefit women and families. I mean, that's what this work is about. And we appreciate your interest in being here and trying to learn more about it.
I could not sum it up better, so I will leave it with Kara's closing.
Awesome. Well, as you both know, we are very grateful for you to take the time out and chat with us today. If we have any additional questions, I will make sure that I provide my contact information at the end of the presentation, so that if anyone's listening and they think of something, they can send it over. So I do want to highlight very quickly these upcoming COE events. We have a session on telehealth, a rural telehealth and mobile health for children and youth, as well as an office hour for AAPI communities. So I wanted to just throw that out there. Again, you will be getting the slides and the recording so that you'll be able to have access to this. And then also a few COE resources here related to perinatal health. Please check those out. All of the links are here for you to check in and listen. Next slide, please. And so here's my contact information. If any of you have any questions, just jot this down, shoot me an email. I will make sure that I touch base with both So and Kara and get any questions answered for you. But definitely thank you for all jumping in, listening, sharing, asking questions. Kara just dropped her brief in the chat, so I would definitely check that out. I have that up on my computer now to read when we hop off. So I think that is our last slide. Yes, thank you. So we will wrap up. Again, if you all have questions, let us know. Please make sure that you do the evaluation survey that will be emailed to you or will pop up on your screen as you wrap up. And we will sign off. Bye. So bye, Kara. Thank you so much. Thank you, team, for all your hard work.